Shock that is failing to respond to ward-based medical treatments is a common indication for admission to ITU. In this video, we will go through the different types of shock. Firstly, shock is defined as acute circulatory failure associated with inadequate oxygen utilization by cells. As such, treatment focuses on restoring this critical oxygen delivery. The clinical picture will vary depending on the cause of shock, but two main objective markers that are often used in identifying shock are a low blood pressure and raised lactate. The other clinical manifestations can be deduced by thinking about the consequences of impaired perfusion of various organs. For example, reduced perfusion in the brain can manifest with a low GCS, and in the kidneys it can cause reduced urine output, and in the peripheries the capillary refill time may be prolonged due to capillary vasoconstriction. The temperature of the peripheries may vary depending on the type of shock. For example, in hypovolemic shock, the peripheries will be cool to touch due to peripheral vasoconstriction, whereas in distributive shock, widespread vasodilation may mean that the peripheries are warm to touch. First of all, if a patient is noted to be hypotensive, it's important to clarify whether it's a true reading. For non-invasive readings, you should ensure that the patient has an appropriately sized blood pressure cuff. If they have an arterial line in place, check that the transducer is roughly at the level of the patient's right atrium. If the arterial line waveform appears dampened, it might be suggestive of an issue with the arterial line apparatus itself. There are a few basic physiological equations that you should commit to memory to better understand hemodynamics. Firstly, blood pressure equals cardiac output times systemic vascular resistance, and then cardiac output itself is a product of a heart rate and stroke volume. These two equations together can be used to help identify the types of shock affecting the patient in front of you and determine the most appropriate treatment options. Based on the equation, a low blood pressure can be caused by a reduction in cardiac output or a reduction in systemic vascular resistance, or, of course, a combination of the two. To help conceptualize the different types of shock, I've split the causes into forms that primarily affect cardiac output and those that primarily affect systemic vascular resistance. Please do remember that though we're describing these forms of shock as different entities, they quite often coexist. In cases of reduced cardiac output, it can occur due to reduction in heart rate or a reduction in stroke volume or a combination of the two. Causes of shock due to reduced stroke volume can be broken down into hypovolemic, cardiogenic, and obstructive. In hypovolemic states, the ventricles don't fill sufficiently during diastole and hence aren't able to achieve an effective cardiac output. Hypovolemia can generally be split into the loss of blood, as in trauma and GI bleeding, or loss of fluid, as in diarrhea and vomiting, or excessive diuresis. Cardiogenic shock occurs due to an intrinsic cardiac defect that impairs output. This includes impaired contractility, for example due to a myocardial infarction, valvular dysfunction, and arrhythmias that can affect ventricular filling. Obstructive shock is a rarer form of shock that occurs due to a mechanical obstruction of the heart and large vessels. This includes intramural occlusions, such as a large pulmonary embolism, and extramural occlusions, such as cardiac tamponade or tension pneumothorax. In cases of reduced cardiac output secondary to a reduction in stroke volume, patients with a functional autonomic nervous system should manifest a reflex tachycardia. On the other hand, patients can also develop a low cardiac output and hence blood pressure due to a significant reduction in heart rate, as is the case in complete heart block. In such cases, drugs with a positive chronotropic effect and or pacing will be the mainstay of treatment. Note that certain common medications like beta blockers can dampen the body's ability to mount a reflex tachycardia in shocked states. The other important category of shock is distributive shock. This refers to shock caused by a decrease in systemic vascular resistance and encompasses septic, anaphylactic, and neurogenic shock. Septic and anaphylactic shock are both characterized by widespread vasodilation and an increase in capillary permeability, precipitated by various mediators such as microbial toxins and pro-inflammatory cytokines. Neurogenic shock is a rarer type of shock in which the sympathetic outflow that plays an important part in maintaining vascular tone is compromised. This can result in widespread vasodilation. Septic shock is the most common form of shock seen in ITU, followed by cardiogenic and hypovolemic shock. Neurogenic and obstructive shock are much rarer. We'll finish briefly by talking about arterial line traces. This is what a single heartbeat will look like on an arterial line trace. During ventricular systole, the blood pressure will rise rapidly. Its highest point is the systolic pressure. The pressure will then fall during diastole, and the pressure at the bottom of the downward slope is the diastolic pressure. The difference between the two is called the pulse pressure. The mean arterial pressure, or MAP, is equal to the diastolic pressure plus 1/3 of the pulse pressure. The small notch on the downslope is called the dicrotic notch. This occurs when the aortic valve closes, causing a transient dip in the arterial blood pressure before the elastic recoil of the aorta causes a slight increase in blood pressure. In ITU, blood pressure targets are usually set based on the MAP, as it's thought to be a good overall indicator of blood flow and perfusion pressure. A target MAP of 65 is set in most circumstances, though there are some settings in which a higher MAP may be sought, such as traumatic brain and spinal injury patients.